Welcome back to Mondays with the Midwife. I'm Regina Kaiser, certified nurse midwife, doctor of nursing practice, and co-owner of Breathe Birth and Wellness. Last week on Mondays with the Midwife, we talked about evidence-based practice and how it was like a three-legged stool that includes clinical research, clinical expertise, and patient preferences. In tonight's episode, we're going to talk about natural induction of labor, what the evidence has to say about that, in order to know whether we want to use them to induce our labors. In order to understand what we are trying to achieve with induction of labor, let's talk about the labor process for a minute. One of nature's most potent inducers of labor is commonly overlooked, the baby. As babies near term, they let off chemical messengers, adrenocorticotropin hormone to be exact, otherwise known as ACTH. One of the jobs of this hormone is to signal mom's brain to work with the baby in the uterus to get labor moving. So this hormone also stimulates a cascade of hormones that initiate contractions, stronger contractions, to prepare baby for birth outside of the uterus and to prepare mom and baby both for breastfeeding. So some of the hormones that are involved in this cascade, the ones we're going to discuss, are oxytocin, endorphins, adrenaline and other stress hormones, and prolactin. Oxytocin is known as the hormone of love. This one is very important to labor. It causes increasing strength and frequency of contractions, which help thin out the cervix, cause it to open and dilate, help you push your baby out, help you push your placenta out, and also helps limit the amount of bleeding that a mom has in the postpartum period because it causes such intense uterine contractions. Ways that we can promote our body's normal production of oxytocin is to always do our best to stay calm and confident and relaxed during the labor process. Avoid disturbances that we know are going to be annoying, like unwanted visitors or procedures that we know we would like to avoid. Also remaining upright and using gravity to help our baby descend into our pelvis and onto our cervix can help with increased oxytocin as well. And then stimulating your breast tissue, which is something we're going to talk about later in this episode. The next one is endorphins. Endorphins occur more readily when you don't use pain medicine in labor or an epidural. Endorphins will rise steadily in the presence of pain. And high levels will actually produce this altered state of consciousness, which can help us actually cope through the pain of labor. Also makes us feel very alert and even euphoric once our baby is delivered. Low levels of endorphins can also lead to problems, though, because when you have low levels of endorphins, you'll experience excessive pain and potentially poor coping. So our goal should be to remain calm, comfortable, and confident with the birth process, and hopefully those levels of endorphins will continue to rise to help us with that pain as it rises. Adrenaline is the next one. This is the fight or flight hormone. Women who feel threatened in labor often will have severe pain. Increased adrenaline, which can occur when there is too much pain or poor coping, can actually slow down and even stop labor in its tracks. And then a potential to lead to fetal distress. And when you have fetal distress, then you're going to end up with unwanted interventions in your labor. So you can decrease your adrenaline by doing a few things. I've already touched on it several times with the other hormones, and it's important with this one as well. Staying calm, feeling relaxed, being informed and prepared for your birth are the main ways you can keep your adrenaline levels down. And also developing a strong trust in your body and staying connected with that. Choosing a calm and peaceful place to give birth, a place that you know you feel Anxious every time you walk in is not a place you're going to do well when it comes to your adrenaline levels. So pick a place that makes you feel safe, calm, peaceful, and confident. Avoid disrupting procedures and things that you know are going to also increase your adrenaline. The last one I want to talk about is prolactin. Prolactin is known as the mothering hormone. It's what helps prepare our breast and our baby and our bodies for breastfeeding, and has also been known to enhance those maternal behaviors. So after talking about just your basic hormones that occur with spontaneous labor, let's talk about when an induction of labor might be necessary and you would want to consider it. Induction should be offered if the outcome would potentially be better if the baby is born. So some reasons for this might be that the mom's had premature rupture of membranes, which means the membranes rupture, but the labor hasn't started. And this is going on for some time, not just 2 hours, but potentially maybe the next day that no labor has occurred. We need to get labor started so that you don't end up with increased risk for infection. Another thing would be preeclampsia. If you're having high blood pressure, pressures that are dangerous to mom and baby in labor. They can affect the uterus and the way that, or the placenta, and the way that the blood flow gets to baby. So we would want your baby to have the best outcome. So that's another reason. And then also post-dates pregnancy. So when we say post-dates, it's not 39 and 6 or 7, which would be 40. But 42. So if your pregnancy is moving toward 42 weeks, there's no sign of labor, then you might want to consider trying to get labor moving. The longer you go after 41 weeks, the greater your risk increase that you could end up with negative outcomes. So that would be another reason. So what are some things that might work? I alluded to it earlier. Prostaglandins are very important when it comes to inducing labor. So we want to do things that are going to enhance prostaglandins and oxytocin. So I talked about nipple stimulation earlier. Nipple stimulation does cause contractions, and it has been studied. There are 6 trials evaluating 719 women. When you compare women who have done nipple stimulation and breast stimulation compared to women who have not, the majority of those will go into labor in 72 hours in the group that did do breast stimulation. The complication with breast stimulation is that it hasn't been tested in high-risk populations, and one of the concerns is that stimulating your breast in labor can cause contractions that are a little unpredictable and can last a little longer. So just like with any other induction method, you have to be cautious with how much to do. You can overstimulate your breast and overstimulate your contractions. Sexual intercourse is another thing that is often recommended for induction of labor. And surprisingly, only one study was resulted in 2001 with 28 women. So not a lot of evidence scientifically or from a research standpoint to say that any meaningful conclusions can be drawn. However, this is one area where clinical expertise and patient preferences will have to come into play. It makes sense that sexual intercourse would work for induction of labor because human sperm is known to be the highest or most potent in prostaglandins of any body fluid. So there are a lot of prostaglandins, which is a substance proven to ripen the cervix, will help labor to start and help the cervix to ripen. The thing about sexual intercourse is you can't say that it's the act of sex itself or it's the prostaglandin only, because there are multiple things going on there. So you also have an actual manipulation of the lower uterine segment that's occurring. That could contribute to it, as well as if you have an orgasm during intercourse, that's going to release oxytocin, and that's going to help as well. So the mechanism by which intercourse works is unclear. It's probably a combination of the 3. But that being said, unless you have a medical reason for avoiding intercourse, like a placenta previa, which is where your placenta covers the cervical os and your doctor has told you or provider has told you that intercourse is unsafe, then it can be an enjoyable way to initiate your labor. Another method is membrane sweeping. Membrane sweeping is when the physician or provider place their fingers into your vagina through the cervix, which has to be open, and separates the membranes from the cervix in a circular motion clockwise. So the problem with this procedure is that for many women it's uncomfortable, and it can lead to spotting, and it can lead to premature rupture of membranes if the membranes were to rupture during this procedure. So a study of 22 different trials, including 2,797 women, indicate that we would have to perform a membrane sweep 8 times to avoid 1 induction of labor. So only 1 out of 8 times is this a successful procedure. So according to this studies, routine sweeping of membranes does not appear to offer clinically important benefits and should be weighed out prior to performing it. The last thing I'm going to talk about tonight is amniotomy, or breaking of your water. This practice was introduced in 1756 by obstetrician Thomas Denham. He recommended rupture of membrane to accelerate your labor, and since then has become a very popular practice. The mechanism of how it works is still very unclear, but it's thought that when your membranes are ruptured, prostaglandins, which ripen your cervix, are released, and oxytocin increases, which in theory should lead to stronger contractions and quicker cervical dilation. Conversely, Dr. Vincent in 2005 advocated that leaving your membranes intact will allow them to bulge and put pressure on your cervix, which causes a softening and shortening and leads to cervical dilation. Your amniotic membrane has 2 layers. There's an amnion that's next to the baby or against the baby, and there's a chorion that's against the cervix. And then you have your cervix, and the 3 of them work together. Your amnion and your cervix both produce a prostaglandin that cause ripening, will help your cervix to dilate and soften. The chorion that lays in between them has a prostaglandin deoxyhydrogenase, which actually prevents the 2 of them from causing you to have your baby prematurely. As you get close to term, that chorion produces less of that hormone, or the deoxyhydrogenase, so then those 2 layers, your amnion and your cervix, can communicate. And his theory is when you break the membranes, then you keep those 2 from communicating, and can actually have the potential to slow down your cervical dilation. So he doesn't advocate for that to happen before you're advanced dilated. So concerning rupture of membranes, if we look at 15 studies that involve 5,583 women with an aim to increase contractions and shorten your length of labor, the results show us that there's no statistically significant difference between women in the amniotomy or the water breaking group compared to those in the control group which didn't get their water broke in that first stage of labor. So the length of labor is not any different. The cesarean risk are not increased, and maternal satisfaction or APGAR scores of less than 7 at 5 minutes are also unaffected. So the author's conclusion based on this review is that if there's not a clear indication for it, amniotomy should not be introduced routinely as a part of standard care. So as you see, there are a lot of decisions to be made about induction of labor, and one thing to always consider when you're thinking about inducing labor is that the benefits of inducing labor outweigh the risk of just waiting to see if my baby and my body and my uterus can all work together to start this process without additional help. Next week on Monday with the Midwife, we'll continue discussing other methods commonly utilized to initiate labor. Thanks and have a great night.